Welcome to the topic of Episclera and Sclera. In this topic, we will discuss about the anatomy of sclera and episclera, episcleritis, scleritis, staphyloma, and scleral discoloration. Look at the anatomy of the sclera. Sclera is the outer fibrous coat of the eyeball. Suppose this is the eyeball. So the outer fibrous coat of the eyeball is the sclera, and it forms the posterior 5 by 6 of the globe. So the posterior 5 by 6 of the globe is sclera, and the interior 1 by 6 of the globe is the cornea. It is composed of the collagen fibrils which do not have a uniform orientation as in cornea. As we learned in the cornea, there is uniform orientation of the collagen fibril which provides the transparency to the cornea, but in sclera it does not have a uniform orientation. So it will be opaque and it does not play a role in the refraction. So then what is its important functions? The important functions of the sclera are the protection of the intraocular contents, transmission of the blood vessels and the nerves. The posterior part of the sclera is modified into sieve-like structure called lamina cribrosa. So the posterior part of the sclera forms a sieve-like structure. It is called as the lamina cribrosa, and through this the fibers of the optic nerve pass through. So the fibers of the optic nerve pass through the lamina cribrosa and it leaves the eyeball through the sclera. And third function is the attachment of the extraocular muscles. So all the recti muscles are inserted into the sclera, due to which it helps the movement of the eyeball in different directions. The sclera is opaque, but it has the important functions like the protection of the intraocular contents, transmission of blood vessels and the nerves, and the attachment of extraocular muscles. Now, what is episclera? So, the dense vascular connective tissue which lie between the sclera and the Tenon's capsule. So, between the sclera and the Tenon's capsule, there is lie the episclera, and it is deep vascular connective tissue. The vasculature, if we understand the vasculature, it will help us to differentiate between the scleritis and the episcleritis. So the superficial tortuous blood vessels are the conjunctival blood vessels, and if we see the straight blood vessels radial, these are the superficial episcleral plexus, and the deep scleral plexus is arranged in the crisscross fashion. So this is one way to recognize. The superficial tortuous blood vessels are the conjunctival, the straight and the radial are the superficial episcleral plexus, and the blood vessels arranged in the crisscross fashion are the deep scleral plexus. These superficial tortuous blood vessels are the conjunctival blood vessels, and these are the superficial and tortuous, and these radial blood vessels are the episcleral blood vessels. It might seem to differentiate between the conjunctival and the scleral plexus is that the conjunctival blood vessels and the superficial episcleral plexus, it blanches with the topical 10% phenylephrine. So if we install the phenylephrine into the eye, so the conjunctival blood vessels and the superficial episcleral plexus, it blanches with the use of the 10% topical phenylephrine, but the deep scleral plexus do not blanches. Now the episcleritis. It is the common self-limiting condition. It will resolve on its own, and it can be seen more commonly in females, usually idiopathic. We do not know its cause, and it can resolve on its own. But it may be associated with the rheumatoid arthritis, and SLE may be recurrent. If it is occurring recurrently, then we should keep in mind the collagen vascular diseases RA and SLE. The symptoms of the episcleritis are these patients do not present with the pain, but there is like mild redness, mild discomfort, irritation, or foreign body sensation. there is no pain in episcleritis. There can be mild redness and discomfort, irritation, or sensations of foreign body. In science, there is obviously congestion of the blood vessels, but it can be of two types. The simple episcleritis, can be of the diffuse or sectoral. It means that the whole of the eyeball is congested, or a part of the eyeball is congested. But in nodular episcleritis, which is the second type, a nodule appears to be inflamed red. And how can you differentiate between the episcleritis and the scleritis? It is that it blanches with the 10% phenylephrine. If you put the topical installation of the 10% phenylephrine, the episcleral blood vessels will blanches. And second, we can do the slit lamp examination. If we perform the slit lamp examination on the congested part, it shows that the flat interior sclera surface, the sclera surface is flat, it is not raised. If it is raised, then it shows the scleral edema. This slit examination can show the difference between the episcleritis and the scleritis. See, this is the slit which shows that the interior surface of the sclera is flat, so it is called as the um, episcleritis. If it is raised like this, so it will point toward the scleritis. But we have learned that the congestion typically interpretable. It can be of diffuse type, the whole eye is red, or it can be of nodular type, the only the nodule is red, and then it blanches with 10% phenylephrine. The congestion decreases on installation of 10% phenylephrine, and the slit lamp examination shows that the interior surface of the sclera is flat. If it is raised, then it will be scleritis. If it is flat, then it will be episcleritis. How we treat it? The treatment is generally of the symptomatic relief. We give the lubricants to decrease the irritation, redness, and if it is not working, then we can use the topical NSAIDs. And if the severe form is present, then we can use the topical steroids. But if it is occurring frequently, then we should keep in mind the collagen vascular disorders RA and SLE, and we should suspect the patient for these two diseases if there is recurrent bouts of the episcleritis. Next topic is scleritis. So scleritis can occur anteriorly or posteriorly of the sclera. In anterior scleritis, the two forms occurs: non-necrotizing scleritis or necrotizing scleritis with the severe inflammation. In the anterior scleritis, it occurs more commonly in the female. Again, it is of can be diffuse type or nodular type. In diffuse type, the whole of the eye is sclerites, and in nodular only a nodule is involved. Symptoms of the scleritis is the dull aching pain which was in the morning. So it is not only of the redness, but there is also dull aching pain which was in the morning. What we read in the episcleritis, there is only redness, mild irritation, or foreign body sensation. But in scleritis, there is pain, the lacking pain which was in the morning. And in necrotizing scleritis, severe pain may radiate to the jaw and the temple. So in the necrotizing scleritis, the pain can radiate to the jaw, to the temple and the jaw, and pain is not relieved by the analgesic. In episcleritis, the over-the-counter medication analgesic can relieve the pain, but in necrotizing scleritis, it is not relieved by the analgesic. This shows the scleritis. And what signs we see in the patient? There is congestion. Again, it can be of diffuse or localized, sectoral or the nodular. It can involve only one part of the eye. or the it can be of the nodular congestion, and then installation of the phenylephrine. So if we install the 10% topical phenylephrine, the superficial vessels constrict. The superficial vessels, which are the episcleral vessels, they will constrict, but the deep vessels do not. On slit lamp examinations show the scleral beam displacement. So if we do the slit lamp examination, it will show the raised part of the sclera, and it is due to the edema. And scleral thinning due to necrosis. In necrotizing scleritis, there is thinning of the sclera, so the deep choroidal uh, plexus can be easily visualized, and it results in the bluish discoloration of the sclera on healing. So this bluish discoloration is nothing but due to the thinning of the sclera. The underlying choroidal plexus can be seen. What we have read, that the scleritis can be of the anterior and the posterior. Anterior scleritis can be non-necrotizing and the necrotizing with severe inflammation. Anterior scleritis can be seen more commonly in females. Again, it is of diffuse and nodular type. The symptoms are the dull aching pain which works in the morning, and in a severe necrotizing scleritis, the pain radiates to the temple and the jaw and not relieved by the analgesic. There is also redness present. And what signs we see? There is congestion, and installation of the phenylephrine do not blanches the deep vessels, and slit lamp examination show the scleral uh, edema and the raised sclera. And due to the scleral thinning, there is a visualization of the choroidal plexus, due to which the sclera appears blue. Anterior scleritis is the condition which needs to be treated, because it can cause the following complications. If it is moves anteriorly, it can affect the cornea, and it can cause the peripheral ulcerative keratitis, ulceration of the cornea. And if it moves deep, then it can involve the uvea and cause the uveitis, glaucoma. And due to the scleral necrosis, thinning of the sclera can easily perfuse. Now the posterior scleritis. The posterior scleritis is even more extreme condition, because it is potentially blinding condition, and it's seen majorly in the young patients. The younger population is most commonly affected by the posterior scleritis, and it may be bilateral, and it is difficult to diagnose. So the posterior scleritis is the most extremely important condition, because it can potentially blinding condition and seen in young population, and maybe bilateral, and it is also difficult to diagnose. In the posterior scleritis, the patient complains of the pain and redness, but it may not correlate with the severity. The severity is very high, but the symptoms are very less. What are the dangerous signs of the posterior scleritis? So we can see the congestion and subretinal mass. The edematous sclera forms a mass under the retina, and uh, due to the mass, there will be choroidal folds. The choroid can form the folds, and the exudative retinal detachment. So the mass, so below is the scleral edema, above it the choroidal folds, and uh, this exudate can move, and it can results in the retinal detachment. This can be seen in this image. So as we see, there is a different color present here. So this is the subretinal mass. Above it the choroidal folds, and above this is the exudative retinal detachment. And it can also presents with the disc edema. So there will be the disc edema, and we can see the tortuous blood vessels. These are the due to the scleritis. And myositis, which is the pain during eye movements and tenderness at the muscle insertion. If the patient is moving the eye, there will be the pain or during the eye movements and tenderness at the muscle insertion. So if we uh, palpate the muscles insertion, there will be tenderness, and also there will be proptosis. So what are the signs? There will be congestion of the blood vessels, and there will be subretinal mass due to the scleral edema. Above it will be the choroidal folds, and above will be the retinal detachment due to the exudate. And there will be also the disc edema and myositis, which means the pain during the eye movement and tenderness at the muscle insertion, and there will be also the proptosis. The symptoms cannot correlate with the severity, as it is involving the choroidal folds retina, so the severity is much higher than the symptoms. So what investigations we do? So we do the USG B scan, in which we see as the T sign. So the T sign can be seen on the USG B scan. If we need the further confirmation, then we use the CT scan orbit. What are the causes of the scleritis? Either the scleritis is the anterior or posterior. These are the following causes. So the non-infectious causes are the rheumatoid arthritis. Majorly these are the autoimmune conditions: SLE, polyarthritis nodosa, Wegener's granulomatosis, and the relapsing polychondritis type polychondritis. So these are the autoimmune conditions. And what are the infectious causes? Are the tuberculosis, herpes zoster, leprosy, syphilis. These are the infectious causes. And we can also see the post-surgical scleritis, because if we during the cataract surgery we give an incision of the sclera, so after the post-surgical there will can also we see the scleritis, and it is usually of the anterior. Based on the history and the investigations, we need to rule out the cause of the scleritis. Either it can be post-surgical, infectious, or non-infectious. If we have identified the cause of the scleritis, then we give the treatment accordingly. If it is infectious scleritis, for example, it can be due to the TB, then we use the appropriate antimicrobial therapy. If it is due to the TB, then we have to give anti-tuberculosis therapy. And we can also add the systemic steroids depending on the scleral involvement. And if the non-infectious scleritis, then we have to use the topical steroids, and we also need to step up to the systemic steroids and the systemic immunomodulatory or cytotoxic agents. So we have come to know that the episcleritis is a self-limiting condition. It can resolve on its own, and it is very mild condition. And if it is recurrence occurs, then we should keep the RA or the SLE in mind. And the scleritis is the more serious condition, anterior and the posterior scleritis. And the scleritis can be due to the non-infectious causes, and it can also be due to the infectious causes. So we keep in mind the difference between the episcleritis and the scleritis. The next terminology is the scleromalacia perforans. So, scleromalacia perforans is a necrotizing anterior scleritis, but keep in mind it is without inflammation. It is necrotizing anterior scleritis, but it is without inflammation. There will be no edema or signs of the inflammation. There will be only mild irritation, and it occurs in elderly female with the rheumatoid arthritis. And what we see, there will be yellow plaques near the limbus. The yellow plaques can be seen near the limbus, but it is without vascular congestion. There will be no redness or the deep vascular congestion, and the slow progression with the scleral thinning. The scleral thinning and the necrosis is very slow in progress, and scleral perforation is extremely rare. So how I can uh, tell you that this is the scleral thinning? Because the underlying choroid plexus is visible, and it can be seen as the bluish discoloration of the sclera. The name is the scleromalacia perforans, but the perforation is extremely rare in this case. Next terminology is the staphyloma. So staphyloma is the ectasia protrusion of the outer fibrous coat of the eyeball, either the cornea or the sclera, with incarcinated uveal tissue. So there will be the protrusion of the cornea or the sclera, but with the incarcinated uveal tissue. There will be protrusion of the cornea or sclera, but with incarcinated uveal tissue. The uveal tissue, including it can be iris, it can be ciliary body, or the choroid. They are attached to the cornea and the sclera in the cephyloma. So it can have the different types, and depending on the uh, part of the outer fibrous coat, cornea or sclera, or either the incarcinated tissue is iris, ciliary body, or the choroid plexus. What are the name of types? The interior staphyloma, intercalary staphyloma, ciliary staphyloma, and equatorial staphyloma, and the posterior staphyloma. So the interior staphyloma is at the cornea, and the intercalary staphyloma is at the junction of the limbus, and the ciliary staphyloma is near the ciliary body, and the equatorial is at the equator, and the posterior is almost the posterior of the sclera. The interior staphyloma. Interior staphyloma is caused by the perforated corneal ulcer. If the corneal ulcer is perforated, the iris comes near the cornea, becomes attached to it. The cornea is perforated, and the iris tissues become attached to the leftover cornea, and in the process of healing, the pseudocornea is formed, and it is formed by the fibrinous exudate and the fibrinous tissue covered by the epithelium. So all these protrusion is called as the anterior staphyloma. This is the image of the anterior staphyloma, in which the corneal ulcer occurs uh, and becomes perforated. The iris becomes attached to the leftover cornea, and in the process of the healing, the pseudocornea is formed. The intercalary staphyloma occur at the limbal area. So the protrusion at the limbal area lined by the root of the iris. So the incarcinated tissue is the root of the iris, and the protruded area is the limbal area. So what are the causes? If there is healed peripheral ulcerative keratitis, so if the keratitis were present at the cornea, uh, at the limbus, corneal scleral junction, then it can leads to the protrusion of the limbal area, or penetrating trauma at the limbal area, or Marfan syndrome. And due to the increased size or the curvature of the cornea, there can also be seen the astigmatism, and the angle distortion leads to the high intraocular pressure. So the ciliary staphyloma, it is the protrusion of the sclera about 3 to 4 millimeter away from the limbus, lined internally by the ciliary body. So the protrusion occurring near the ciliary body, it is called as the ciliary staphyloma. And what is the causes? The causes can be the healed scleritis, inflammation of the sclera which is healed, a rheumatoid arthritis, or the trauma penetrating injury. The posteriorly occurs the equatorial staphyloma. As we gradually moves toward the posterior, there first we can see the equatorial staphyloma. It is the protrusion of the sclera in the region of the equator, and the incarcinated tissue is the internally lined by the choroid. And what are the causes? Again, the healed scleritis, or it can also be seen in pathological myopia. Then the posterior staphyloma. So the posterior staphyloma, it is the protrusion of the sclera behind the equator, lined internally by the choroid. So uh, the posterior to the equatorial staphyloma, there can be the posterior staphyloma. It is the protrusion of the sclera, and internally lined is the choroid. What are the causes? The causes can be the pathological myopia or posterior scleritis. So the different types of the staphyloma, anterior is the cornea, perforation of the cornea lined by the iris, uh, and intercalary at the limbus, lined by the root of the iris, and ciliary staphyloma at the uh, sclera near the ciliary body, and lined internally by the ciliary. body. And the equatorial, it is the posteriorly and protrusion of the sclera line internally by the choroid. And as we move more posterior, the posterior staphyloma, a protrusion of the sclera line internally by the choroid. We also need to know the scleral discoloration. So the bluish discoloration, it is the thinning of the scleral collagen with visualization of the underlying choroid. What are the causes? The bluish discoloration can be seen in osteogenesis imperfecta, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, Marfan syndrome, Turner syndrome, congenital glaucoma, in which there is stretching of the sclera due to the congenital causes, high myopia, and the heel scleritis, and the nevus of Otta. And the yellowish discoloration. The yellowish discoloration can be seen in jaundice. The black brown discoloration is seen in the alkaptonuria, and the rusty brown discoloration is seen in the hemochromatosis, in which there is iron overload. So we have done the topic of the sclera and the episclera. So what we learned the anatomy of the sclera, then scleritis, scleromalacia perforans, staphyloma and its different types, and the causes of the discoloration of the sclera. The bluish discoloration causes, yellowish discoloration causes, black brown discoloration, and the rusty brown discoloration.